Welcome to this explainer. Today we're diving deep into a clinical update on the diagnosis and evidence-based management of osteoarthritis. Whether you're a family physician, a rheumatology practitioner, a PT, or an orthopedic specialist, this one is absolutely for you. We're stepping out of the textbook and looking at the real-world clinical decision-making that actually transforms patient outcomes. Let's get right into it. We've got a tight, highly structured roadmap for you today to help move our practices toward holistic, guideline-based care. We'll hit the wear and tear myth, presentation and risk factors, structured clinical assessment, the role of imaging, evidence-based multimodal management, and finally, optimizing long-term outcomes.
To really understand the stakes here, consider this number for a second. Over 607 million people globally are living with osteoarthritis. It's the absolute leading cause of lower extremity disability in older adults, making up a massive share of global years lived with disability. And as our population ages and obesity rates continue to climb, this burden in our clinics, it's only going to grow.
Section 1. The wear and tear myth. Let's start with a massive paradigm shift that challenges what a lot of us were taught in training. For decades, we misnamed this condition degenerative joint disease and basically brushed it off as just passive wear and tear. Well, scratch that. That is a total myth. Osteoarthritis is an active, whole joint disease. It turns out the itis in osteoarthritis is actually dead on. It's driven by this incredibly complex interplay between abnormal biomechanics and a localized innate immune response that basically leads to failed joint repair.
So what's actually going on under the hood? It's literally a biological demolition site driven by cytokines and chemokines. Look at how systemic factors like age and obesity team up with local biomechanical trauma, think meniscal damage or ligament tears. These triggers cause the synovium and the periarticular fat pads to dump inflammatory mediators into the joint. These mediators stimulate chondrocytes to pump out proteases like matrix metalloproteinase 13, which literally chew up the articular cartilage matrix. Section 2. Presentation and risk factors. Let's bring this into the real world. Imagine a typical patient. We'll call her Sarah, a 55-year-old former athlete sitting in your exam room. What brought her there?
Well, like our hypothetical patient Sarah, osteoarthritis doesn't just randomly strike. It has a really strong predilection for specific sites. We're mostly seeing it in weight-bearing joints, the knees and hips, as well as the epiphyseal joints of the lower cervical and lumbar spine. Over in the hands, it classically targets the first carpometacarpal joint, right at the base of the thumb, along with the distal and proximal interphalangeal joints.
Now, when we're assessing Sarah's risk profile, we have to separate what we can't change from our modifiable targets. And here is where things get really fascinating. Obesity. It is not just about extra mechanical load on the knee. Adipose tissue is actually hormonally active. It pumps out adipokines and inflammatory cytokines, creating a systemic low-grade inflammatory state in the body. That totally explains the paradoxical reality of why obesity is a massive risk factor for hand osteoarthritis too.
Your typical patient will present with function-limiting, usage-related pain. But here's the defining question you absolutely must ask. What about morning stiffness? In osteoarthritis, that stiffness crucially resolves in under 30 minutes. That's a major differentiator from the prolonged stiffness we see in autoimmune arthropathies. You might also find crepitus, a restricted range of motion, and in the later stages, pain that just won't quit, even at rest.
Section 3. Structured clinical assessment. Okay, so how do we confidently diagnose this at the point of care?
Since the diagnosis is primarily clinical, here's your actionable checklist. First, walk through a thorough history hunting for that classic usage-related pain. Second, on your physical exam, check for joint line tenderness, crepitus, and bony enlargements, like Heberden nodes at the DIP joints or Bouchard nodes at the PIP joints. Third, we highly recommend getting a functional baseline. Use assessment tools like the COAS, WOMAC, or even just a simple timed up-and-go test. And finally, rigorously rule out your differentials. While you're doing all this, always keep an eye out for red flags. If your patient mentions prolonged morning stiffness lasting over an hour, or if the joint is hot, red, and swollen, or if the disease is progressing incredibly fast, hit the brakes. These point straight toward rheumatoid arthritis, crystalline arthropathies like gout or CPPD, or infectious arthritis, and those require a completely different game plan.
Section 4. The role of imaging. Let's talk about a major crossroad in our clinical journey, deciding when to actually get an image.
Look, a huge pitfall in our clinics is assuming a one-to-one correlation between what we see on an X-ray and what the patient is actually feeling.
Come on, we've all been there, right? We look at a horrific bone-on-bone radiograph and expect the patient to be in agony. Or conversely, we see a pristine joint space and dismiss their severe pain.
The big takeaway from the clinical guidelines is exactly this mismatch. Routine imaging is not required to diagnose osteoarthritis. Why? Because structural damage often completely fails to correlate with patient disability. We need to treat the patient sitting in front of us, not the imaging report. Save the imaging for when you're unsure of the diagnosis or when there's a sudden, weird change in their symptoms.
That being said, when we do get imaging, look for the 4 classic radiographic hallmarks. You can see them clearly on these knee and hand radiographs: asymmetric joint space narrowing, subchondral bone sclerosis, the formation of osteophytes at the joint margins, and subchondral cysts. Just keep in mind, these confirm structural damage, but they absolutely do not dictate your immediate treatment plan.
Section 5, Evidence-Based Multimodal Management. All right, we have a confident clinical diagnosis for our patient. Now how do we build the treatment plan?
Evidence-based care is all about a gradual step-up approach. It starts right at the bedrock of conservative management. Day 1 means patient education, structured physical therapy, and supported weight loss. If the symptoms demand it, we step up to pharmacology, usually starting with topical and oral agents. If pain is still hanging around after a few months, we can consider intra-articular injections. And we only look at orthopedic surgery when every single non-operative measure has failed.
Now, current AAOS guidelines actually challenge some of our old-school habits. There is incredibly strong evidence backing sustained weight loss, supervised or even unsupervised exercise, and oral or topical NSAIDs to improve pain and function. On the flip side, and this might ruffle some feathers, they strongly warn against using oral narcotics like tramadol because of the high adverse effects. They also advise against the routine use of intra-articular hyaluronic acid, since recent high-quality trials just aren't showing consistent clinical benefits.
We have to be hyper-vigilant about common pitfalls. For instance, watch out for overprescribing NSAIDs without weighing those GI and cardiovascular FDA black box warnings. Also, be honest with your patients. Corticosteroid injections usually only buy them about 3 months of relief. And, crucially, stop referring patients for arthroscopic partial meniscectomies for simple degenerative meniscus tears. The guidelines are clear. Unless the patient has true mechanical locking symptoms, that surgery offers little to no benefit over regular physical therapy.
But of course, there is a right time for surgery. When a patient's pain and quality of life are still severely impacted despite our absolute best non-operative multimodal efforts, meaning they put in the work with weight loss, PT, NSAIDs, and injections, and they have radiographic proof of moderate to severe joint destruction, that's when referral to orthopedic surgery for joint replacement is the perfectly appropriate next step.
Section 6, Optimizing Long-Term Outcomes. Let's bring it home and talk about how we support these patients over the long haul. Remember, OA is rarely a quick fix.
Managing osteoarthritis effectively means managing the whole patient. We have to address the massive burden of comorbidities. Chronic pain leads directly to sleep disturbances and depression, which then loop back and amplify their perception of pain. We need to do regular fall risk assessments, especially for our older folks. We must set realistic expectations. This is a marathon, not a sprint, and use shared decision-making so the patient is firmly in the driver's seat of their own care plan.
As we wrap up this explainer, I want to leave you with a provocative thought. Now that we know osteoarthritis isn't just simple wear and tear, but a highly complex, whole-body inflammatory and biomechanical issue, how is that going to change your very next clinical assessment? Are you just going to look at the joint? Or are you going to treat the whole patient? Thanks for joining me today, and I'll catch you in the next explainer.